All right, why don't we go ahead and get started? It is 12:01, so I think we are good. Welcome to Medical Grand Rounds at the University of Colorado. Really happy that we are all back here in person. Good to see a relatively crowded room. I like that. Just as a little teaser, upcoming talks on February 15th, we're welcoming Dr. Margaret Herridge. She's a world's leader in ICU care and end-of-life care from the Toronto General Hospital. She'll be talking about life after critical illness. And then on February 22nd, we're going to have a visit from Dr. Karen Maddox from WashU, who's going to speak about the effect of health policy on health outcomes. As a reminder, there is CME and MOC credit for all talks this year. You can use the QR code that is up there for about 2 more seconds. And questions will come primarily from our live audience, but also thank you to the chief residents who will be fielding questions in the Q&A section on the Zoom. And now I am really pleased to welcome 2 speakers today, Dr. Gabby Frank, who I will introduce first, and Casey Bowden. Dr. Gabby Frank is an associate professor of medicine. Professor of medicine. Thank you. Well done. In the Division of Hospital Medicine here at CU. She's also the medical director of the biocontainment unit at Denver Health Hospital Authority and the director of faculty development and advancement for the Division of Hospital Medicine, as well as the chair of the Excel Group, which is the Expert Council for Clinical Excellence and Leadership in the Department of Medicine here at Colorado. And she is the program co-director of the DOM PAGE program, which is for mid-career women's leadership development certificate. She did her undergraduate work and medical school in Buenos Aires, where she graduated with honors. She, at the Hospital General de Agudos. She then did one of several internships and residencies, also in Buenos Aires. The first was in internal medicine, second in emergency medicine. And then we got to work together when she came to the States and repeated her senior residency here at the University of Colorado. She also has a number of advanced training certificates. She was a member of our Teaching Scholars program. She is involved in the Leadership and Education Administration program through the CU School of Medicine, and also the Leadership and Health Policy program through the Society of General Internal Medicine. I'd also like to introduce Casey Bowden. She is an assistant professor of medicine. Good, making sure. Soon to be promoted, I suspect. Also here at Colorado. Casey is the associate division head in the Division of Hospital Medicine. She's the medical director of the CARE Clinic, which is the Clinical Assessment and Rapid Evaluation. She's a senior clinical lead at the UC Health Office of Advanced Practice. She's the director of Extended Recovery Services, line here at UC Health, and she is the lead AVP for the University of Colorado Division of Hospital Medicine. She did her undergraduate work at the University of Kansas, where she got a BS in nursing. She also graduated with honors and the highest distinction. She then did her master's in science and nursing at Georgetown University, followed by an advanced practice fellowship here at CU. And they really are, I was about to say both rising stars because I am looking at my piece of paper, but they are both truly rising stars in act and in name. Gabby was the CU Rising Star for the Department of Medicine in 2017. And she's been, we were just talking about her physical exam skills, a recipient of the Golden Stethoscope Award from the CU School of Medicine twice in 2017 and 2021. And Casey is also really highly recognized for the work that she has done. She too was a rising star in 2020. And in 2022, she was named the recipient of the Division of Hospital Medicine Innovator Award. And so I think I will stop there and just introduce our 2 speakers today. Thank you for coming to Grand Rapids.
And that's our talk. We just came here for just to be recognized. So thank you for being here. Thank you, Dr. Connors. I was only going to say, hi, I'm a hospitalist. I'm Gabby. But that's good, I guess. Okay. So we're going to be talking about APP physician best practices and how to leverage multidisciplinary teams to create thriving systems. We are both, as Dr. Connors already mentioned, faculty of the Division of Hospital Medicine, and I'm going to skip all the titles since we were a little more selective and put less things there, but I'm going to move that forward. We do not have any conflict of interest, and all the images that we're using are credited appropriately or used with permission. And basically what we're trying to do today is to define some of the concepts around the thriving frameworks, to explore and describe some barriers and successes in collaborative team-based models. And we're going to try to propose an implementable framework for developing and supporting thriving people, teams, divisions within the Department of Medicine. For those of you who do not know me, I do have an accent. Surprise. So if you don't understand what I'm saying, just lift your hand. I'll say it again at the same speed with the same accent, but by the third time you'll get it. So you're gonna leave like, totally, now I know how to speak Argentinian. So my part of the talk is going to be just to define some of the concepts around thriving and what it means to thrive in our workplace. And then Casey is going to be talking about all the great work that the Division of Hospital Medicine is doing within like team and collaborative teams working. So if you look in a dictionary, basically you're going to see that to thrive is to flourish, to prosper, to progress towards or realize a goal despite or actually because of the circumstances. Thriving is usually defined as characterized by success of prosperity, but what is more important is that you cannot have a thriving team if you don't have thriving team members. So we need to focus on each individual in our department to actually help them thrive, and then hence we're all going to be thriving. So I'm going to start with this statement, and it's going to do like, we're going to play that game, guess what I'm thinking? Here, and you all know that game because we do that to learners all the time. So I'm going to read it. Steve worked at what he loved. Love was his supreme virtue, his God of gods. When his son Reed was born, he began gushing and never stopped. He was a physical dad with each of his children. He fretted over Lisa's boyfriends and Erin's travel and skirt length, and Erin's safety around the horses she adored. None of us who attended Reed's graduation party will ever forget the scene of Reed and Steve slow dancing. Do any of you know who is this Steve person? Yeah, it is Steve Jobs. Who says Steve Jobs? Oh, come on. I guess that's why you're the boss. So basically, this is the eulogy of Steve Jobs' sister when he was talking about her brother. And what is important is that when we talk about individuals and achievements and success, what people remember after we're gone is not our professional achievements per se, but is what and how we thrive, what made us thrive, who we were as a person. So in order to actually do better jobs, we need to help our people thrive, because then they're going to have the better self when they come to work. It's not because we want better performance, but it's because we want happy people in what they're doing. So I don't know if any of you read this book, Thrive. It's actually a pretty good book. I did the audiobook first, and then I ended up buying the book so I could underline stuff. But basically, Arianna Huffington, who founded the Huffington Post, wrote this book, Thrive. And basically what she says is to try to redefine success. That are traditionally success is defined by power and money. And she tries to add the third metric for success, that is to thrive. And she proposes 4 pillars for thriving, and that is well-being, wisdom, wonder, and giving. And when we think about medicine, there's of course a lot of boxes that we can think. I was like, well, maybe power, we can consider that power is going to be our positions, our academic rank, our promotion, our leadership positions. Money is self-explanatory, but when we focus on thrive, that is the part that we're going to be talking about today, and how we help people thrive, we need to think about well-being. And I'm not going to get in burnout at all, because that is a whole year of ground rounds to actually trying to address burnout. So I'm not going to get there, but we can think about like time management, appropriate resources, flexibility in the schedule, some life balance. And I'm not saying life-work balance, because without life, there's no work. So what we try to aim for is a life balance that will... It's not me. It's not me. Maybe it is. No, it's not me. And one of the very, very important ones is values. So it's very important that all of our people feel that their values are being represented in the work that they do, and hopefully that they share the same values as their institution and their division or the team that they're working with. When we think about wisdom, it's very important that we can provide the opportunities for everybody to develop professionally, to actually mentor others or offer mentorship to other people, and just to be able to teach. When we think about wonder, we need to maintain like the sense of wonder to make sure that we help people thrive and be creative and be able to come up with like good innovative projects and have some independence of thought. You still can hear me, right? I know I'm loud, but. And then when we think about giving, like providing people with the opportunity to actually perform some advocacy and some community work. And of course, when we think about giving, like we all know that we have a lot of senior mentors that dedicate their time to some of our learners. So that's of course part of giving. Another really good book that I like about Team Thriving, who read this book? Well, I highly recommend it. It's not an audiobook, so you cannot cheat and listen to it in the car. You kind of have to read it, but has very, very big font and it's easy to read. So this is actually from Gallup, came out in 2021. And they based all the results of this book on over 100 million interviews that they did of people in over 160 countries, from Afghanistan to Zimbabwe. So they say that they represent over 98% of the world's population on the results that they got. So they did this, they collected all this interview over, of course, several decades. But what they were trying to do since mid 20th century is to try to come up with what works and what doesn't work. And we can see how one of the authors of the book says that well-being is the catalyst organizations need to cultivate engaged, thriving employees who perform at their best every day. Your employees' well-being influences every aspect of your business performance. So again, this probably we all say, yeah, duh, we know that, but how do we get there and what are the things that they define? So what they tried to understand first with all of those questions was, what is the best possible life and what are people? Like, where are at the best possible life in the present and what do they think the possible life is in the future? So they actually came up with 2 questions to do a quick assessment of where people are in their well-being or the best possible life scale. And they called this the Gallup net worth. So those 2 questions, what they call the net thriving score. So basically the first question is, when you think about your best possible life, on which step of the ladder, that is 0 to 10, would you say you personally feel you stand at this time? With 0 being the worst possible life and 10 being the best possible life. And then the second question was basically, on which step of the ladder do you think you will stand in about 5 years from today? Same thing, 0 being the worst, 10 being the best. And this is about like how they estimate the best life possible. And that gives them an idea of current thriving plus future engagement and how they can change the things to make people feel better at the workplace. And basically what they realized is that there were 3 big categories of people. They were either thriving, struggling, or suffering. So the people that are thriving are usually, they rank present and future life, like either present about 10 and above and future life 8 and above. And those who are struggling are usually 4 and below for both present and future life. But what they notice is that people that are struggling, they usually report a lot more worrying about financial issues and work issues than the people who are thriving. So again, some of the statements that come from the book and the findings that they got from this 100 million interviews is that 1/3 of Americans, and of course, this is not, of course, the 100 million, since this is only for America, have shown signs of clinical anxiety and depression, and the current state of suffering globally has risen significantly. What is important to know is that the thriving employees have 53% fewer missed days because of health issues, whereas the struggling employees have greater diagnosis of depression and anxiety and other burdens. And this translates into loss of productivity, and even more so when data shows that thriving individuals are 20% more likely to have thriving team members. So the employees engaged in their work report fewer negative emotions, even during challenging times. So that's another reason why it's very, very important to try to make sure that we help our people thrive when we're at work. And this is the same statement as before, but I think it's important to highlight that this is good for everybody. It's not just for our people and their lives, but it's also for our productivity and our performance in our work. So again, this is some of the other findings from Gallup. So based on all, they just decided well-being out of all these questions, they tested over 100 questions that they have used over the years, and they try to see which was and this is in different languages and different cultures and different countries and different life situations. And basically what they found that was statistically significant was the 5 different kinds of well-being and the 5 different themes that actually affect well-being. And one was the career well-being. And basically it's like, how do you occupy your everyday? Like, are you happy in what you do every day that basically sustains the rest of your life? The social well-being and how having loved ones made a difference. Financial well-being, and like basically this relates to effectively managing their finances. Physical well-being, of course, health and being able to have enough energy to do their stuff. And then community well-being, to have a sense that they belong where they live and that they have some engagement with their community. So the other thing that was interesting is that what they studied all these people around the world is that 66% of people are thriving in at least one, with only 7% thriving in all 5 elements. So that basically gives us a lot of room to work with to actually provide people with some relief and maybe help them and foster thriving. So some of the other key findings that they had was that 7 in 10 people are struggling or suffering. So when we see the scale of thriving versus struggling and suffering, we know that 7 out of 10 are basically not thriving. Burnout, of course, we all know is an official occupational syndrome recognized by the WHO. 28% of US employees experience burnout, and that goes above 50% in some areas of healthcare and some specialties and some settings. And with those employees are 63% more likely to take a sick day, those who have burnout, and 23% more likely to go to the emergency room. Another thing that was very curious is that 85% of large employers in the United States actually offer well-being programs, but only 60% of the employees actually are aware of those programs, with only 24% of those who are aware actually engaging on the programs. So again, that gives more room to actually being a little more intentional about what we offer to try to keep our coworkers thriving. And 78% of the world's population is not engaged with their job. And when we say 78%, that doesn't mean University of Colorado, Denver Health, the VA, but what it means is like probably we are close to that number. So again, we have some work to do. One thing that I think is very important is that out of these 5 themes, they have an additive effect. So if somebody's only thriving in one of the 5 areas and we can get them to thrive in the second, that has an additive effect in performance and happiness actually. So that can make it a lot better. So when we think about healthcare, it's a very complex environment and there's no simple solutions, and we know that. And there's a couple of themes that have been identified to actually be able to foster thriving in complexity. One is to understand that we actually work in a complex environment. And usually most of the definitions and groups that have been working to trying to define a complex environment, they bring certain themes such as emergence, adaptation, network, unpredictability, autonomous agents, self-organization, and chaos. Basically, that describes healthcare. And basically, it needs us to basically adapt and be amenable to change and transform. One other thing that is very important is to be able to deal with ethical dilemmas and value systems. So we need to make sure that people's values are represented in everything that we do in order to help them thrive. Emotional intelligence, as you all know, is very important. And then when we think about the leadership style, everybody talks about there's a lot of different leadership styles, and we all know about this. But when we talk about the traditional leadership models and what these authors are recommending is a complex adaptive leadership, which basically has a more intentional shared governance that is focused on complex systems views, that has a dynamic structure, that basically is focused on being transformational and giving people the tools to actually be able to adapt to change rather than preventing change. And basically, they usually do dynamic strategic planning rather than, okay, we're going to do a strategic planning for 1 to 5 years, and this is what we're going to do, without taking into account that, as we saw in this one, complex environments have all these different things that will come to it, and chaos is there and unpredictability. So we need to make sure to have some dynamic strategic planning. So again, we're going to get back to this later with Casey, but we need to make sure that values, in order to have our teams thrive, we need to make sure that values are represented in our culture of our teams, the operations, and the advancement. As I said before, we're not going to go into burnout right now, but when we think about this third metric for success is the big one for addressing burnout, and we need to make sure that we address all of these areas and help people thrive, but also remembering that multidisciplinary teams can actually facilitate many of these areas, particularly when we think about adaptive leadership and how this shared governance and people can feel this ownership on all the things that you do and help them thrive. Okay, so how about a division of hospital medicine and why we're giving this talk? It's a very large division, and of course, we have physicians and APPs in all the 3 hospitals. We have over 200 faculty in our division that actually have a lot of different niches and cover a lot of different services, from eating disorders to, and again, these are services and niches areas of expertise and not necessarily services, but we have consultation services, the acute care for the elderly, correctional care, DEI, housing and security, fertility, fracture and geriatric trauma care, medical oncology, triage services, nocturnes, procedure services like point of care ultrasound, biocontainment and disaster medicine, medicine works, both for teaching and non-teaching, med peds, clinical research, operational research, QI, palliative medicine, medical education, et cetera, et cetera, et cetera. So we have 208 faculty in our 3 main hospitals, and then we have 45 affiliate faculties that are in the other affiliate institutions. Out of the 208, we have 49 instructors, 9 senior instructors, 94 assistant professors, 52 associate professors, and 5 professors. And we also host a lot of different educational opportunities within the Division of Hospital Medicine, including the Advanced Practice Fellowship, the Clinical Faculty Scholar Fellowship, the Clinical Scholars Program, the Evidence-Based Medicine Fellowship, a lot of different programs to teach POCUS at a lot of different levels in all 3 hospitals, the HTP program, the HESP, and Global Health, just to name the ones that were easy to remember. So how do we help our team thrive, like within hospital medicine? When we talk about traditional success, also takes us to what is the traditional metrics of success academically, and this traditionally is climbing the ladder, and we can think about recognition, scholarship, academic promotion. You can see the percentages there is where our faculty are in the Division of Hospital Medicine at each rank. Leadership opportunities, mural and extramural funding. However, when we're thinking about thriving, what really matters is to try to help our faculty do some self-assessment and actually understand what will help them thrive. So basically, they need to ask themselves, like, okay, what are my interests? What are my values? How do I bring this to work? What is my personality? Maybe there's some services that I would prefer not to do, and there's some other services that I can do a better job at and that will help me thrive. And basically explore this, what the skills are for each individual. And then what is most important is how do you define success? Because success may look a lot different for a lot of us. Like some people may just define success as a lot of outdoor activities. Some other ones actually really like, and that is okay. We don't all need to share the same definition, but we need to understand which is our own, so we can set goals that actually will fulfill us and not just do what other people think, do what we think other people want us to do. So when we think about thriving, what does it mean for the Division of Hospital Medicine? And actually the leadership of the division did a survey of the faculty. And one of the questions was, what does thriving mean to you personally? And this is some of the quotes that came from that survey. That I'm valued and respected and that my voice is heard. That we're all bringing our best work to the table. That the whole division is thriving. In other words, no one is left in the dust and we all succeed. So you can see how when people define thriving, it's not about 2 more publications in the next 2 months. It's like more philosophical in a way. And then the goal is like, if we get to be the best in class in thriving people, like how do we think that our work life will change? And again, this is some of the quotes. Like, I have the ability to make progress in my career beyond just clinical work. Happy providers will communicate with and handle our patients more efficiently. And with increased diversity in the group, including DEI, will reduce bias in care provided to patients. And we all see patients as people and looking at different factors that impact their health. So in a way, when we think about thriving for the division of hospital medicine, it's a lot more holistic than just helping them to get more publications done. So, and I think that this is probably mirrored in a lot of different divisions, and it's not unique to the division of hospital medicine. So now the question is, how do we leverage multidisciplinary teams to create thriving systems? And I'm going to pass the baton to Casey Bowden.
Awesome. Thanks, Gabby. So like Gabby said, my name is Casey Bowden. I'm a nurse practitioner in the Division of Hospital Medicine. Before I get started, I have a couple of small corrections as far as my intro. One is that I'm actually the co-associate division head with my esteemed colleague, Dr. Adam Meyer, and also the co-interim director of the Office of Advanced Practice with my amazing colleague, Katie Dickerman. Not really emphasizing that as a point of clarity for myself, but more an emphasis on my passion for collaborative leadership models, and that I hope kind of a theme that resides throughout the rest of my presentation today. So now that we've heard a little bit about the global concepts of thriving both within complex systems and personally, my hope is to take that and actually examine what we as physician APP multidisciplinary teams do, not only to create barriers to thriving, but what are some options for actually overcoming those barriers and hopefully actually creating or delivering a tool that we as APPs and physicians and division and department leaders can use on a day-to-day basis to set our priorities to work towards creating thriving systems. So thriving systems is the ultimate goal. That's the pinnacle. But in order to think about the future, we need to learn from the past. So I want to do a 30-second history lesson. 30 seconds of NPPA history. I also have one quick disclaimer. First of all, today in my talk, I'll be referring to NPs, nurse practitioners, physician assistants collectively as APPs, and the highlights predominantly on inpatient and ambulatory APPs as opposed to CRNAs or nurse anesthetists or nurse midwives, also who live under that umbrella of advanced practice provider, but less the focus of the discussion today. So nurse practitioner, the history of the role of the nurse practitioner is actually invented here at the University of Colorado. So we have a good start as far as our legacy, but it was invented in the 1960s, essentially as a result of baby boomers. There was a rapidly growing pediatric population, which then lent itself to an increased need for pediatric primary care, particularly in rural and underserved areas. So in 1965, the University of Colorado School of Medicine received a $7,000 grant, which Dr. Henry Silver and Loretta Ford used to collaborate and create the first nurse practitioner program. Similarly, very same time frame where the physician assistant role came from, also in the 60s, as a result of both the end of various war and different Army people that were in the Army and medics returning from overseas, but also this increase in baby boomers, resulting in both a need for increased primary care providers, but also to readapt the skills of Army medics to be able to function well in the real world. And so in 1967, the first PA program was created at Duke University by Dr. Eugene Stead Jr. I also noticed this is a quote that Dr. Eugene Stead had written about the inception and creation, and he does very specifically say how he needs men to fill this role, which we have overcome that barrier, but they were different times, so that's okay. But the themes in both of these is that there was both necessity and urgency. But why? Because of a rapidly growing patient population, necessity and urgency that was rooted in an imminent need for delivery of patient care. We have encountered something very similar to this in the last couple of years with a little global pandemic, which required all hands on deck, where we had the same culture, the same setup, where we had both urgency and necessity. However, as both professions have evolved, as the NP and PA profession have evolved, the reasons for utilizing NPs and PAs, independent of our global pandemic, have actually transitioned to being a little bit more value-based. So in this study that looked at why APPs are utilized in academic medical centers, The primary reasons for using APPs were things like one of the major ones is resident duty hour restriction. So trying to meet the need of optimizing well-being of our residents, but still meeting, again, that need for direct patient care. And other things were things like increasing patient throughput, improving patient access, improving quality, safety, length of stay, improving continuity of care. So very value-based metrics. And what I think has happened over the years as a result of this is that question of urgency and importance then ends up varying. So if I'm a resident and I'm saying, I'm working 120 hours a week and this isn't sustainable, the utilization and implementation of APPs might be high urgency, high importance. However, if I'm a hospital CEO, that level of urgency and importance is very different. Similar in other complex systems, the need for patient access, that might be really different in a practice that's brand new, that's actually trying to build up their model, versus somewhere where patients aren't able to be seen for months on end. Similar things that we are dealing with in our own hospital, things like patient throughput. The urgency and importance for that is really different when we are at 113% capacity, and we are really needing to do everything we can to optimize throughput versus if it was a hospital that's consistently running at 70 to 80%, and our financials actually depend on having patients in the hospital. There's a larger discussion there about overall healthcare system and our incentives. Again, not the topic for today, but the bigger point I'm trying to make is that I think that we have, as the model has adapted, this urgency and importance ends up varying, and our needs and utilization for APPs has varied with it. And that's resulted in us creating barriers to having thriving teams and thriving systems. So I want to go into the barriers a little bit. There are several. Obviously, we're talking about a very big and global topic as it pertains to APP physician best practices. And I want to talk about a couple because, in part because the title of our talk is APP physician best practices for thriving systems. So I want to focus on things that we as APPs, physicians, and systems do to create barriers to thriving models. So first thing I would say is, again, as the progression we have an upswing in the progression of APPs. A lot of the focus in APP literature has been comparative in nature. So it is comparing APP outcomes to that of our physician counterparts. And it has been, and then a lot of our larger legislative or governing bodies and authorities, their push or their emphasis from a legislative standpoint has been about full practice authority or autonomous practice. And it's well intended, but I would argue that, first of all, I don't think any of us as providers, I think operating and defining success in a form of comparison is debilitating. That is negative, right? And instead of looking at instead of approaching our APP physician literature in what is the most optimal model, we try to essentially kind of establish our foothold by comparing ourselves to physicians. And what's the natural response to that for physicians? It's going to be say, we don't have the training that I have, and you don't have the hours and years of experience, and like you didn't have to do 4 years of med school and then the indentured servantry that is residency. And that is accurate, that is fair. That pushback is fair, but it's creating pushback on something where instead of being compared, so the literature, we really should be focused on collaboration versus comparing, and how we complement the physician model, or how our models and our background and expertise complements one another, as opposed to how our practices compare. The others, and so like I said, I think what this has resulted then in is actually push back from physicians. So this is an article from the American Medical Association, which, if you go to their website, it's rather unfortunate and egregious, I would say, as far as the way it describes and discusses APPs. And this is, a narrative article that they published about a patient presented to an emergency department where an APP missed the diagnosis, but it was too late, and 2 hours later they were dead. So, this shock value, and then they wrap up the article by saying, fighting scope creep is critical component in the AMA's recovery plan for Americans physicians. Please look at our website and access this here. And then you go to their website and they have all these plans for, the reason we need a recovery plan for America's physicians is because we're not thriving. We're barely surviving. And we'll talk about this model, but so instead of leveraging teams, one of the large medical organizations is actually encouraging separation and division and exclusion of teams. And I think that this is just a travesty because ultimately, I just presented an article that said the reason we actually use APPs is for value-based metrics. They are things that are supposed to be improving the lives, not only of our patients and our colleagues, but our physician partners. We're supposed to be improving each other's lives as well. So we've created these barriers for ourselves based on the focuses of some of our large organizations, but on either side. I'm not intending to be ever accusatory towards any one field or another. This is to say we all have responsibility in rethinking the way that we build models and rethinking them so we're building them focusing on collaboration and complementing one another as opposed to competition and comparing. So when in the division of the hospital medicine, when people ask us come out of residency and say, well, what is your APP? What do APPs do? What is your model? And the way I always describe it is saying the whole is greater than the sum of the parts. The the guiding principle that we have in developing our APP physician models is that by optimizing team-based models, we hopefully have better care that's high quality, that's safer, that's more efficient, but where we also have happier patients and happier providers. We want to leverage our team to improve all lives. So we talked a little bit about APP and physician barriers that we present, and now I want to talk about some of the system and operational barriers. And some of this lies in the funding model, for APPs. So often APPs are actually hospital supported, and we already talked about APPs are often hired for value-based metrics, not productivity-based metrics. They are not hired to say we want to increase WRVUs by 40%, compared to this physician, or we want to increase revenue by this much. The driving reasons for using APPs are value-based in nature. However, many systems, APPs are funded by hospitals. Well, a hospital system requires funding to operate. That is fair. We all should have the same ultimate goal, which is hopefully providing the best patient care and having thriving people. But their metrics of success then become operational or productivity based in nature. But our reasons for utilizing APPs are actually value based in nature. So we actually have a misalignment. And because we haven't thought about that and addressed it in the way that we have approached the creation of our models, it creates year over year disruption, inconsistency, and change to those models, which I think inhibits our ability to move those forward. So by not thinking about the fact that the driving metrics of the funding and support model for the APPs or the hospital, that by not defining metrics of success well with our stakeholders, we actually can be limiting our ability to promote APP practice. So we've talked about the barriers, and now I want to go into what are steps to success. And like I said, hopefully present with an operational framework that can actually be used to establish priorities within divisions and departments. And so from this, I will give a little bit of background of the Office of Advanced Practice State Interview Project. So the Office of Advanced Practice, which is duly funded by the School of Medicine and the hospital, we did a survey in 2017, which had about of UC Health APPs. So APPs are practicing here in the UC at Anschutz. We had about a 68% response rate, which was really good. And overall, there was general themes of dissatisfaction, feeling undervalued, and this, this general tone of considering leaving the workforce. I think we've heard echoes of this in a lot of the recent Weldom and different surveys that have come out. So this led us to do a stay interview project. And so the goal of the stay interview project was actually to reach out to APPs in different departments and division. And first, we wanted to actually create the conceptual framework for thriving, identify the themes and barriers in thriving, and then develop recommendations at that group, department, and division level. And so first, I said we wanted to actually create that conceptual framework for thriving, because my focus is not just APPs, it's multidisciplinary teams within a complex system, right? So first I had to say, what's the problem? Like, what does that model look like? And in doing this work, as I put this model together, I realized, or again, my conceptual framework, which I put together, we operate in kind of 3 domains. And I separated that as surviving, sustaining, and thriving. And then there's 3 major population components. There's patients, people, and system. And one of the problems is, and ultimately, what thriving should look like is if we were to create a true model for thriving for a complex system, should be something like a tripod. And right now, there's competing metrics. We probably deal with this in the emergency department. The emergency department has a 2-hour throughput metric, but my metric of success is decreased readmissions. So we're actually competing with each other. Similarly, if a hospital's budget bottom line looks really good because we're at 120% capacity, but our providers are getting burnt out, that is not cultivating a thriving system. So in a perfect world, what thriving looks like in a system is that for our patients, they have excellent outcomes and high satisfaction. Our people have low attrition, high recruitment, highly retained, highly satisfied. And in our systems, that they have a high return on investment, they are able to continually grow. And like I said, I think of these as a tripod that without one, if one is off, you are at a minimum leaning, if not falling over. All of these things should be thriving in order to have a thriving system. So in doing this work, I ended up doing interviews for about 60 APPs throughout the system. And so first what I created, again, in an operational framework, was I recognized that there's certain guiding principles in developing thriving teams. And those guiding principles, what I found were kind of embedded in these 3 in these 3 values. And the first one was trust, the second is support, and the third is value. Again, when you're getting to this value is where I really think of what we're thriving. But also you can't get to one without the other, is what I realized. If an APP or if an APP physician team don't have trust in one another, or they don't, if that trust isn't there, it doesn't matter how many yoga classes you give. It doesn't matter how much you increase their pay. If that isn't there, if that feeling of just being treated fairly and equitable doesn't exist, you're never going to feel supported. And it doesn't matter if we decrease your patient volumes, like those things. So in order to get to the next level, you have to attain essentially the one below it, much like kind of a Maslow's hierarchy of needs. But what I found in kind of, again, these guiding principles or values for thriving teams. And so then as I thought more on and kind of did some content analysis on these interviews, I said, okay, here's really the guiding principles, but what are the driving forces behind all of those? How can I take this, turn my philosophically geared brain into something that's not tangible that people can use? So in order to do that, what are the driving forces behind that? And in trust is really embedded in a lot of things around operations. And I'll talk a little bit more about that as we, again, kind of build out this model. But I think the core of operations for any division or any group often is aligned in these themes of equity, transparency, and a lot of that, it can often center around our salary and schedule practices. I also say, like, salary and schedule, like, get those right. Those are a lot of times like your core of equity for larger teams. Around support, there's a lot in the culture. Are APPs included, or are APPs excluded from, for example, M&M conferences or faculty division meetings, or do we treat people different within our culture? Is there opportunity for bilateral feedback, or is our culture hierarchical in nature? And then the third was advancement. And this can be both clinical and academic, but is there opportunity for growth? Not only in, I would say the other part with advancement is also this element of appreciation and recognition. And so I want to give some examples. I'm going to highlight a few of these, the really large themes that presented themselves, again, in part and in hopes that as division or department leaders, that these are maybe things that if they resonate, things like that you take back to your division and maybe do a little bit deeper dive in looking at. But as far as operations, salary practices was really emphasized in nearly every group, every department that I did interviews for. And again, this isn't on, I just want more money. It was really around these themes of equity, transparency, and process and consistency. Like, what is that process? Is it consistent? And going back to what I talked about with barriers and system barriers, the funding model for APPs in that hospitals support APPs also can sometimes lend itself to compression, in that if we're not actively essentially advocating to ensure APPs are staying up to different up to salary benchmarks, they can actually kind of linger in the system, and their salary can fall behind benchmarks. And then all of a sudden you've created this toxic undertone because there's this concern of, well, why am I not getting these raises? And often it's not because you don't have support from your division leadership. It's that these processes for APPs and physicians can vary. And so it's falling through the cracks. In culture, actually, I'll go into the salaries a little bit. So as far as what's the solution for that, for salary best practices, much like physician salary best practices, trying to utilize a transparent and consistent framework to set salaries, and then ensuring that APPs are kept up to speed on that. One place that we lag for APPs is benchmarks don't exist in the robust fashion that they do for physicians. So this is really challenging. So as an institution, we've actually worked really hard in collaboration with UC Health School of Medicine to create to do a yearly market analysis of APP salaries, and then create a framework for setting APP salaries, which is based on years of experience, broken down into 4 domains of acute care, ambulatory procedural based, and critical care. And we distribute this yearly. It is like public information for anybody. And what we encourage is that groups implement this practice. And it eliminates inequity, and it encourages transparency and builds trust. So we have, so once we get to trust, then we can start working our way up the ladder and get to thriving. As far as culture, this gets, again, back at our metrics of success, and where APPs are kind of falling in tricky spots, because we are getting added to teams often for value-based metrics, but when the year-over-year discussion comes for, like, the time comes for negotiation or for adding APPs, we have very similar conversations over and over, because we haven't taken that time or collectively haven't ensured that our metrics of success are aligned, and then therefore will allow us to grow and optimize our programs and our models. Again, if I say, like, I love having, like, my physician supervisor who I'm working with says, you're so wonderful, and like this would really stink without you, but then the hospital says, I don't care, you need to do this on your own. We're limiting our ability to actually successfully advance that model. So how do we achieve this? Thinking about, as division department leaders, and then also as APPs, what are our metrics of success? How can we make sure those are very clearly delineated within APP physician groups? How can we share in successes? And I think, again, there's some variance here, whether it's in incentive models or things like that, but what are ways that we actually share wins as a team, as opposed to encourage and promote wins individually? And then once we've done this, advocate for that model, to our stakeholders and to our people supporting APPs, and then promote and grow that. And then last, in advancement, and I think this is one I want to highlight again, because this is a very, very consistent theme for APPs throughout our institution. And there's really wide disparities, not only in the Department of Medicine, but all throughout all departments, around how we approach promotion practices for APPs. And I think that there's a really, really great opportunity here. Where do I think this comes from? I think it's multifactorial, but I do think some of it actually gets back to this initial these initial principles of competing versus complementing, and comparing versus collaborating. And this notion of, if somebody else achieves academic rank, that reduces the meaning of my academic rank or my achievement of the academic rate of that academic rank. And I guess the thing that I would just encourage is to maybe explore those thoughts and those feelings a little bit more. And sometimes then the response I will get is, well, APPs, they can't do these things. They don't have the opportunity because they're really hired to be clinical. Well, is that a problem of opportunity or capability? And if it's a problem of opportunity, then that's something that can be addressed at a leadership level, right? Those are systems we can create so that people can thrive. And if you are doing things differently, and it's because somebody has NP or PA behind their name, and that is the sole reason, it is not because an APP shouldn't be performing surgery because they don't have the training, or that it is not based on safety or necessity. we should explore that and we should ask ourselves why. And we should say, is there opportunity to create a pathway for advancement for our APPs? If we don't, we will continue in these 5 to 7 year churn and burn cyclical processes for APPs where we stay in groups and divisions for 5 to 7 years, and because we don't have opportunity to grow, advance, change, we just go to different specialties. And I think that that's really, really disappointing when I think we could be really effective at this question of, hey, how can we make the whole greater than the sum of the parts? How do we work together to optimize all our skills? How do we honor and respect our backgrounds and our differences to leverage everybody? And so with this, I want to share a success story. And, only slightly shameless plug and only partially because I'm highlighting a couple of my bosses. But I think I really do want to highlight where I think this is possible. We really can achieve thriving patients, people, and systems where APPs and physicians can succeed. And one example of this is the University of Colorado Care Clinic. And the Care Clinic, it is essentially an urgent care and advanced symptom management clinic for our solid tumor oncology patients. I took over that clinic as the medical director in 2019 when the prior medical director left. And I saw this opportunity because, again, as a hospitalist, my metrics of success are trying to keep people out of the hospital. But I also have a passion for how can we provide better care at a lower cost. And so I said, well, gosh, I don't want to leave my role in hospital medicine, but can we make a collaborative model? Like APPs can do that. We can span these models. And our physician leaders, Dr. Messersmith, Dr. Marisha Burden, were completely supportive, including our hospital and system leaders, in helping us develop this model where we utilize APPs from the divisions of oncology and hospital medicine to provide these advanced symptom management and urgent care services for our solid tumor oncology patients. It keeps those patients out of the ED and out of the hospital, so the experience is better for them. The cost of a visit is 33 to 50% the cost of an ED visit for the same services rendered. So it's lower cost for the patient, and also it solves a system. It solves a current crisis in our system of capacity and throughput by keeping these people out of the hospital. So this is the pinnacle. This is what we're going for. Everybody's winning here. The patients are winning, the people are winning, the systems are winning. The other things that we've been able to do is leverage APP opportunities within this clinic because it has opened up a world of having either funding models or leadership opportunities. We have APPs that are actually leading collaborative case review for the division of oncology. We've implemented a resident education series. So, not only do we get to talk about, hey, here's how APPs work in the healthcare system, but we actually get to do some teaching, but again, really encourage and focus on, here's how we collaborate with you. Here's how we're a part of a bigger team. And then we have, as a result, APPs participating in quality improvement and fellowship programs to advance their skills so they can be implemented at that local level. So this has been a really rewarding experience of how we can really create a thriving team to leverage a thriving system. And then going back to the operational framework. So this is just an example of something like this that was put together for a different division and department. And again, we talked earlier about urgency, importance, and this kind of works in that way where it starts at your high urgency, high importance. And I would argue it doesn't ever get less important, but your sense of urgency kind of changes as you go across. And certain things, again, as I did these assessments for different departments that I would come up with for an operational framework and a direction that we can move forward and things that we can tackle, help us establish priorities. Here's what we need to work on so that we can get to this state of thriving. So in conclusion, healthcare is increasingly complex, high rates of stress and burnout, and a lot of times this is exacerbated by competing definitions of success. But if we can successfully implement APP physician best practices, it requires focus on collaborative and complementary models as opposed to competitive and comparative forces. And an operational framework to achieve thriving can be an effective tool in identifying divisional or department needs, establishing your priorities, and implementing best practices. And last, I just want to wrap up with this quote from Maya Angelou that I love. And it says, my mission in life is not merely to survive, but to thrive, and to do so with some passion, some compassion, some humor, and some style. And that is all we have. So thank you, everybody, and open up for questions.
So go ahead and open it up for questions from our audience. I think while we're waiting, I'll ask a first question. What are some of the barriers, and this is probably an answer with lots of answers, to why we don't take advantage of a lot of the opportunities that are around us to collaborate? Why do we move into these more contradictory models? And you mentioned, 60% of workplaces offer this opportunity. Very few people take advantage of it. Why do you think that is?
Sure. I do think part of it, again, gets at this core framework and establishing both equity and trust amongst all members of a team. So right now, I think sometimes when there's feelings that opportunity or the opportunities don't exist for certain members of the team in the way they do for others, that can be limiting. And so, and even if it's presented to say, well, why don't you do this? Why don't you take advantage of this? If we haven't done the legwork to establish, hey, not only is there trust, but that this lends itself to opportunity for growth and advancement, I think people can be much more resistant to doing so.
So regarding why 60% of the people only know about the programs and only 25% of the people actually engage on the programs, I don't think I have the answer from the research because that was not presented in the book. My guess is that because this is a recommendation that employers need to offer this because we know that well-being is important and we need it to thrive, there's this okay, it's a check mark, I need to offer this program, but then it's not very intentional, right? And again, I'm just saying, I don't have the research to support what I'm saying right now. It's an opinion. It may be that it's related to the fact that they're checking a box and not being really intentional about it and we're actually engaging about the people to say, okay, we need to do a wellness program. What do you need? Not a wellness, but a well-being program. What do you need us to assess? What are all my key stakeholders, including all the employees and the institution? And so what do you really need us to offer rather than said, this is what we offer, take it or leave it. And then, not being intentional, not really addressing what people need in each institution, then it's not going to do the trick. But as I said, I don't have all the research to support my answer because it wasn't there, but it's my educated guess.
Good. I'll ask one more then. So, I mean, a lot of these things are require the support of large organizations, and I think words like culture appropriately scare us because we're like, "Ooh, how do I change culture?" What do you recommend teams do? Because you mentioned there are very real differences. There are very real differences in work hours amongst members of teams, and salary amongst members of teams, good, bad, and other. How do you suggest that those teams find ways to come together? Because that's something that's probably not research based, but it's something that I suspect you all do all day.
So I guess some of the things I would say as far as how can teams leverage culture, and I think my biased opinion, we do a really good job of this in hospital medicine. Why? I think in part because again, we have core principles, and no matter how much the system changes or no matter how much that system changes, we still have core principles of equity and justice and transparency. And so in that we are very, very conscientious and are we treating people in an equitable way, in a way that is fair and just and equitable. And once we're able to do that, then we can, we can find opportunities to do feedback isn't a one-way process, right? Feedback doesn't go from physicians to APPs. We actually can do bi-directional feedback because that is encouraging equity in clinical practice. And we do that in hospital medicine. And actually is this very positive, encouraging thing where we're able to get, like I said, bi-directional feedback from our APP and physician colleagues. Also, I think looking at ways to support and to recognize one another. So one thing we did in hospital medicine, we created APP physician awards, and it's where our own APPs we created awards that we give to our physicians. And then every physician that is nominated, we write down the narrative, we give them a letter. And it's just this way of saying, gosh, we appreciate you. Nobody loses. It is positive and it is collaborative. And then a couple years after we implemented that, the physicians did the same thing for us. And, and I think that just encourages a really positive team-based culture.
I don't have a lot to add to that, but it's what is important to remember is that there's no thriving teams unless everybody in the team is thriving. So it's we need to make sure that we take the time to be intentional about it and make sure that we incorporate all the team members value and what they bring to, not value like what they bring to the table, but they feel that their values are represented in what they're doing. So it's hard to work in a team where you actually have zero buy-in in what you're doing. Like your job performance is not going to be as good, even if you're a good worker, right? You're a responsible person. We're all type A, so you're going to do your best, but it's probably not as good as if you're invested in what you're doing. So I think that again, building trust, and we need to make sure that we provide and foster everybody thriving and nurture creativity and said, that is a great idea. Let's see if we can implement it. But that idea didn't come from me, so we're not going to do it. So I think that we need to incentivize people to speaking up and not to be afraid, because we never know which one is going to be the next greatest idea. So just be humble. Like we don't have all the answers. So let's listen to what other people have to say. And there's no harm in maybe trying something out. And if it doesn't work, we'll scratch it. Like,
Great. We're right at 1 o'clock. So Casey, Gabby, thank you very much.